High blood pressure exerts a constant physical force against vascular walls. Treating it starts by defining where the safe zone ends and danger begins. On this flowchart, diagnostic thresholds vary. The 2024 ESC guidelines set hypertension at 140/90, whereas the AHA begins at 130/80. The general target is below 130/80, but for patients over 80, clinicians aim for 130 to 139. Diagnosing hypertension requires applying these specific regional frameworks to the patient's age and health profile. Before medications are introduced, the first line of defense focuses on physical lifestyle modifications. Lifestyle modifications are measurable clinical tools. The DASH diet lowers systolic pressure by 8 to 14 points. Weight loss offers a biological exchange rate. Every kilogram lost reduces pressure by 1 point. Additionally, daily sodium is restricted to under 2 grams. These dietary and weight adjustments act as biological levers, reducing physical pressure within the vascular system. When lifestyle adjustments are insufficient to reach clinical targets, clinicians move toward pharmacological management. The standard toolkit consists of 4 primary medication classes: ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazide-like diuretics. Guidelines generally favor dual combination therapy to manage pressure through different biological pathways. If the hypertension remains resistant, spironolactone is introduced as a secondary agent. However, there is a strict safety rule. Clinicians must never combine an ACE inhibitor with an ARB, as targeting this pathway from 2 sides increases the risk of kidney damage. Medication management requires precise adherence to these protocols, as certain drug combinations introduce risks that can outweigh the clinical benefits. Standard protocols are designed for typical physiology. When a patient presents with specific health states, those primary rules are superseded. In pregnant patients, treatment begins at a higher threshold of 150/95. Clinicians utilize labetalol, nifedipine, or methyldopa, while strictly avoiding ACE inhibitors and ARBs due to the risk of fetal harm. If a patient has chronic kidney disease with albuminuria, ACE inhibitors or ARBs become a mandatory part of treatment. Conversely, for a tumor like pheochromocytoma, an alpha blockade must be established before a beta blocker is ever administered. Clinicians also monitor for target organ damage in the heart, kidneys, and eyes. If evidence of organ damage appears, clinicians must investigate for secondary causes, such as primary aldosteronism, renal artery stenosis, or obstructive sleep apnea. Comorbidities and secondary causes transform a straightforward algorithm into a specialized clinical strategy requiring specific medical maneuvering. There is a critical point where vascular pressure stops being a chronic condition and becomes an immediate threat of structural failure. A crisis triggers when blood pressure hits 180/120, and response depends on acute organ damage. Without damage, it's urgency, needing gradual oral reduction. With organ damage, it's an emergency, requiring IV meds to reduce mean arterial pressure 25% in the first hour. The presence of active damage shifts the clinical objective from long-term maintenance to immediate stabilization. Even in emergency settings, specific life-threatening scenarios require clinicians to override standard crisis protocols. For an aortic dissection, clinicians must aggressively drop systolic pressure below 120 within 20 minutes to prevent fatal rupture. Conversely, during an acute stroke, doctors let high pressure persist to ensure brain blood flow, only intervening if it exceeds 220/120. This map of guidelines shows how age, diet, and acute trauma are all integrated into the clinical decision-making process. Modern hypertension management is a process of balancing these data points against individual physiological risks to protect systemic health.